Hey everybody, better late than never. We're just getting started today. Facebook issues, but we got this, okay? So I'm gonna wait a few minutes for everybody to kind of come in. I really hope that you guys watched the decoding lab value session from last week. We decoded the entire CBC, exactly what it meant, how it meant it, and the tone of voice that it means it. So it is really important that we build on that base, because once we start talking about GI labs today, which we're gonna do a lot of, and there's a lot, y'all, we are not gonna play today. So I'm gonna try to get through as many of them as I possibly can today. Will we hit all of them? I don't know. It depends on how smart you are. It depends on how much you're gonna interact with me so that we can move through the material well, but effectively, okay? So a lot of the GI labs are gonna build off the CBC and what we did last week. We take the videos down 24 hours after we start them so that we can get them edited and things like that and get them ready to produce to other people. We are going to offer those of you who we had to reschedule last week, you'll get the free next session. Next session we decided we are going to decode kidney labs. We're going to be doing BUN, creatinine, GFR, creatinine clearance, decoding the whole urinalysis, because what we're finding is students that are coming in, they do not know what a urinalysis is exactly. I mean, I know y'all know it tests the urine, but you have to know exactly what's in it. Otherwise, why would we do it, okay? So we're gonna be doing all kidney things next week, which is gonna be pretty awesome, okay? So I'm gonna let everybody come in and kind of tell me where you're from and who you are while this is all catching up. And then we will get started on our GI labs today, okay? Do remember there is a little bit of a lag, so whenever you guys answer, it'll take a minute, and I'll give you pauses so that you're able to answer effectively. I am really hoping that you're bringing your A game today. All right, so I'm just going to leave it on for just a minute or so that way people can come in, and I make sure we have approved everybody to get in the group. So just breathe, relax, chant something. Who's with me? If you're here, announce yourselves. That way I know you're here. Okay? And then we're about to hit it fast and furiously, so get ready. All right, while people are coming into session, first thing that I want you to tell me is, what do you know about the GI system and different labs that you know we're definitely going to run? Keep in mind, we're going to start with the different organs, the functions of the organs. If you do not know the patho and functions of the organs, you will do terribly on decoding lab values. Because if you don't know what the liver does, how in the world will you know what labs to run whenever the liver is broken, okay? We have some videos on demand on the GI system. I would highly recommend you go take a look and check those out, especially the liver. People forget about the liver. It is one of the biggest organs in the body, not only in size, but also in function. The liver has 13 different functions. So if you do not come in today knowing what the liver does, I'm hoping you leave today. We won't be able to cover every single detail, but you've got to hit the liver and what the liver does. It affects every system in the whole entire body. So I want you guys to tell me, okay, what do you know about GI system? What do you know about the labs? What organs are affected, okay? Oh, Mississippi, hey girl. Take an NCLEX soon. That's super exciting. You're definitely going to need this. All right, so you guys come in telling me what you know, because if I don't know what you know, I don't know what you don't know. All right, so come in and tell me what you do know about the GI system. And it's funny, because when I say the GI system, a lot of people don't know exactly what organs are included. So let's start with the basics. Excuse me, we'll start there. And then we'll move on to the functions of the organs, and then we will do the lab values that are associated when those functions are broken. Okay? Tell me what you know. I know y'all gotta know something, so fingers get on typing. Hey, Sunny girl. There you are. All right, we're gonna go ahead and get started. Maybe it's a shy group today. All right. How we're going to start out talking about decoding lab values. This is a big hot topic for nursing students. They have a hard time with it. Let's start with our function. So we are going to be doing the GI system today. All right. So included in the GI system, we've got the stomach, the liver, the gallbladder, the pancreas, the gut, and they're all working together to make things happen. Okay. I will tell you a little fun story to get us started here so that you understand kind of how the GI system works together. Okay. Are we ready? Do you like soap operas? I hope so, because that's what we're about to do today. All right, liver, big giant liver over here, right? Big organ, does 13 different things. It is not playing. The liver is one of the biggest, baddest bosses of the GI system, and actually one of the biggest, baddest bosses of the entire body, because it does so many different things. Liver is connected to the kidneys. They have a high association together. Liver is connected with the brain. They have a high association together. So you think the liver is no big deal. It's a big ass deal, okay? So the liver, big old giant thing over here, right? Big bad boss. What organ lives right up underneath the liver? Okay, I mean like up underneath it, like I want to be on you, okay? It's this little organ people think is no big deal called the gallbladder. Also a big deal, okay? So the liver and the gallbladder are married because she's right up underneath him, right? Like, what are you doing? Who are you doing it with? Ah, okay. So liver and gallbladder are married, okay? Now the liver is not happy with the current relationship, and so they decide they want to have a polyamorous relationship with the pancreas. All three of those organs are connected. Liver, pancreas, gallbladder. If you piss off any one of these, they're all three going to be pissed off. So one might ask, what would happen if you get pancreatitis? You're going to tick off the liver and the gallbladder, so you're going to have nausea, vomiting, and jaundice, okay? So keep that in mind. Those three have this polyamorous, beautiful Utah relationship, okay? But was the liver satisfied? No, he was not, okay? So the liver said, even though I have this polyamorous relationship, we got this love triangle thing going on, okay? It also has a side piece with our friends, the kidneys, okay? They're in the back for a reason, all right? So kidneys and liver are also highly connected. If the liver's going down, it is taking the kidney down with it, okay? And we'll talk about why. One of the biggest reasons why liver helps to break things down so that the kidney can excrete them. So if the liver breaks, we get cirrhosis, we get hepatitis, what have you. It's not able to break those things down, therefore kidneys are going down with it. So a lot of these labs are gonna overlap. So that's why we started with CBC, then we're going to GI labs, then we're gonna go to kidney, because they are all connected. So you may see a patient that has cirrhosis and they're running BUN and creatinine. That's because you know that the liver side piece is the kidney, so you have to check kidney function, okay? All these labs are going to start to intertwine. So each one of these sessions is going to build on the other, all right? Because we will be talking again and reviewing about CBCs today, okay? So let's talk about, we talked about kind of the GI system and sort of how it works together. So keep in mind, if you have a liver, a gallbladder, a pancreas problem, they're all going to be irritated because they're all connected by ducts and vessels. So if any one of those is blocked, all three of them are going to be mad at us, okay? All right. So let's talk first about the most common organs you kind of will talk about in the GI system. That is our stomach. Now, I always caution students on this because when people say they come into the ER and they're like, my stomach hurts, you know, they can mean anywhere from like here to like my groin area, okay? They mean stomach is like here, okay? We've had patients that come in with stomach pain and it's a pneumonia, but they call it their stomach and way over here and your lung, okay? So keep in mind, when I am talking about stomach today, I literally mean your actual organ of the stomach where you eat food, it goes right into your stomach, okay? That's gastric, stomach, okay? When I say stomach, I do not mean gut, that's down here, okay? Keep in mind, I'm not an artist. Those of you who have seen my videos before know that God did not bless me with that. He blessed me with some medical knowledge, but artistry is a no-go for me, okay? So here is sort of a stomach, okay? Y'all tell me, what is the purpose or the function of the stomach? What's its job? What's its goals? Okay? What do we need it for? What does it do? That way we can decide what kind of labs we need to run if the stomach is not working correctly. That poor stomach looks like a Smurf's foot. Sorry, but you get the point. Everybody, come on, y'all. Tell me what you know. Stomach functions, big things. big things we need to worry about. That way we know whenever the stomach is broken exactly what we need to do to fix it. Nothing. All right, we're gonna keep moving. It's a slow grip today. We're gonna be painful. All right, here's my stomach. All right, so biggest things that the stomach is going to produce are acid and mucus. We have to have both of these things and in the right concentration, okay? I have to have acid to break down my food. If I don't break down my food, it's gonna dump through my gut. Nobody's gonna be happy. So that acid already starts to eat away at your food to prepare the small intestine to absorb it, okay? If I eat a whole bunch of donuts and there's no acid to work its magic through my 12 Krispy Kremes, okay? It's gonna dump right into the small intestine. Small intestine is gonna say this is not ready for absorption. It's gonna dump it, and the patient will have massive diarrhea. No big deal, okay? Just a whole bunch of diarrhea. So we have to have acid production in order to make our food, right? Or to break down our food. But acid obviously would probably hurt. Let me fix this. If it was just sitting on an organ, like I would anticipate if somebody poured acid onto my liver or something that would probably burn, right? So your body naturally creates mucus. So the mucus is going to come and line your beautiful stomach, okay? And that way, whenever we have the acid formation, the acid comes, but the mucus is protective on the lining of the stomach, okay? Another important thing you need to keep in mind, the stomach, actual stomach, okay, it's a very sensitive organ, right? And there's lots of acid production. So if that acid or mucus production gets off, either too much acid, not enough mucus, or the balance becomes off, it will start to erode the stomach lining, causing bleeding. So this is where most of our GI bleeds will come from, either gastritis, peptic ulcer disease, maybe you took a lot of aspirin, which wears away the lining. So bleeding is a big issue in our stomach, okay? You can either see bright red blood, which doesn't happen very often. That would mean that basically there was bleeding and it came right back up, okay? That would be called frank blood. You could see coffee ground emesis. We've heard that a lot in nursing school, okay? That typically means that there's been some bleeding into the stomach, your body's digestive juices have digested it a little bit, and then you're vomiting it back up, so it's like a black color, looks like you ate coffee and then vomited it, hence coffee ground emesis, right? So there's gotta be an equal amount of acid and mucus, right? We know that. Otherwise we start to get bleeds, so watch for GI bleed, especially if they've taken NSAIDs, corticosteroids, drink a lot of alcohol, anything that's super irritating to the line of the stomach, okay? But if we don't vomit this out of the stomach and it goes all through our intestines, which we'll talk about in a little bit, you can also see hemocult blood. You can see that means hidden, right? Hidden blood, where we have to do the little hemocult, you know, take their poop and play with a little wooden stick. That's hidden blood. If I have an actual GI, like an upper GI bleed, that blood is going to be digested all through the intestines and it's going to come out dark colored stool. Anytime in nursing school you see tarry, dark stool, that typically means there's an upper GI bleed. The term for that is called melena, M-E-L-E-N-A, melena, okay? So I need to run some labs on this patient to find out, is this really bleeding or is it not, or what is happening here, okay? If it is bright red blood, like it's coming out of the stool and it's frank blood, bright red blood, that's a lower GI bleed, right? And that term, it's the grossest term in all of nursing school. It's called hematochezia, which is gross because I don't want to put cheese and poop in the same sentence or the same word, okay? So we know our stomach's main purpose is to produce acid and mucus, but it also produces something called intrinsic factor, and that's in our parietal cells, okay? So I want you to tell me, what is intrinsic factor, how does it work in our stomach, and how might that alter our labs if we have a problem in the stomach? And I need y'all to answer. Please, Lord. What y'all got for me? What is intrinsic factor? How does it work? And then what would we look for? Yes, my friend, something with B12 showed us. All right, so thank you for answering so it wasn't so painful. Intrinsic factor is something that's produced in the parietal cells, which are part of the little cells of the stomach. Intrinsic factor is necessary for B12 absorption. So intrinsic factor and B12 have to get married, okay? So they have to like hang out and like each other in order for your body to absorb it. So if there's a problem with your stomach and you are not producing enough mucus, or you're producing too much acid, you have gastritis, you have peptic ulcer disease, something is wrong with your stomach. You may not be producing intrinsic factor normally, which means I can't absorb my B12, which would give me B12 anemia, okay? Because B12 is responsible, or any B vitamins are responsible for nerve health and for healthy blood cells, especially red blood cells. So if there's something wrong with my stomach, I'm not producing intrinsic factor, I can't absorb my B12, therefore I can't make healthy red blood cells, I'm gonna get B12 deficiency anemia. That is also called pernicious anemia, which I'm sure you've heard of before. So if a patient has a major issue with the stomach cancer, severe gastritis, peptic ulcer disease, you need to keep these things in mind because the patient may have a pernicious anemia or a B12 deficiency. Now, how will I know, okay, if this patient has a GI, upper GI bleed, other than watching the stool? That's going to take some time. What are some things, some labs I may see in the stomach to lead me to believe, man, maybe they have a bleed? I'm going to write some things out to the side whilst you guys are answering me. And I will make sure that you guys get a copy of this, okay? So if you can't see it, don't worry. I'm going to explain everything and then you'll get the picture, okay? All right, what y'all got for me? Let's see. Talk to me. All right, so some people are talking about protein, kidney functions, hemoglobin. All right, here are the biggest things you need to know about the stomach. We definitely need to know our B12 levels, right? So we can actually draw levels for B12. If you watched the video last time, then you'll know that the CBC tells us our H&H, which is hemoglobin and hematocrit. That indicates to us if we have a bleed. So if a patient has a GI bleed and they're losing a lot of blood, that hemoglobin and hematocrit level are going to decrease. That will give us a good idea that we have a GI bleed. It does not tell us whether it's upper or lower. That's for us to determine and to do some more digging to decide. But biggest things I want to draw for stomach would be my B12 levels, because I'm worried about a deficiency because of that intrinsic factor. My H&H, so you can either draw a straight H&H or you can go ahead and draw a CBC. It's not going to hurt. You may want to look at things like white blood cell count if there's a huge inflammation. So if my patient had horrible acute gastritis, I might want that white blood cell count too. So you can either just do an H&H if you're looking for bleeding, or you can do the full CBC if you're really looking for a full inflammatory process as well. I wrote up on here too to check electrolytes. Why would it be important in your stomach to check for different electrolytes if you think that there's a stomach problem? And we're talking stomach, right? Like gastric stomach, okay? So while you guys are telling me that, I'm going to draw some other things, okay? All right, so most of the time when you're having true stomach or gastric issues, you're typically going to have nausea and vomiting associated with it. If we have nausea and vomiting, we are worried about them losing potassium, okay? Easy way to remember, and people get confused whenever they're on a nursing exam and they can't decide, okay, what do I lose potassium, sodium, acidosis, alkalosis, what happens in the GI system? All right, easiest way I can tell you to remember it. All right, your diarrhea, super salty. It's made of a lot of salt. You salty when you have diarrhea. Do not lie, it is horrible, okay? So when you have really bad diarrhea, you're losing a lot of salt, which will leave you hyponatremic. When you are vomiting, you lose a lot of potassium. So if you have severe vomiting, you will be hypokalemic, okay? So potassium up here, salt down here, all right? unless on the nursing exam they throw a curveball and say watery diarrhea. Now, if it's watery diarrhea, and you literally have to look for this because they test on this all the time. If it's watery diarrhea, then I'm not so salty. I'm losing mostly water, which would leave me hypernatremic. Got it? Now, as far as acid-base balance, I always say, if it's coming out your ass, you're in acidosis, okay? So if it's diarrhea, you're gonna be in acidosis. The opposite for vomiting. If you are vomiting because you have so much stomach acid, you're getting rid of all the acid, which will leave you alkalotic, okay? Do you understand the difference in the gut? Upper, lower are always going to be opposite each other, okay? So you'll know exactly what electrolyte imbalances you would be looking for and exactly what acid-base balances you're going to be looking for, okay? All right, so biggest things we're looking in the stomach, B12, H&H, and electrolytes, especially if they have nausea, vomiting. If they have nausea, vomiting, we're mostly looking for hypokalemia, okay? Because that's typically the imbalance that we're gonna see with a true stomach problem, okay? All right, we're gonna talk about our triad here, our love triangle, and then I'm gonna make this go like behind here. Then we'll talk about like our small intestine, large intestine, and all the intestine that's in between, okay? We will talk about those too, okay? There's not as many labs for large intestine as there are for these three because there's so much drama that they just have like so much going on. So this is a terrible intestine, I'm so sorry. I need you guys to tell me, okay, what does the pancreas do? What are its biggest jobs? And it has more than just insulin. So don't just tell me insulin. Tell me all the jobs of the pancreas and what it does, okay? And the different kind of labs you think I may be able to draw. The pancreas does a lot more than people think. It is a forgotten organ. It is kind of towards the middle, like where I actually drew it where the stomach is, which is true. It's kind of towards the middle. Sometimes it goes over a little bit to the left side on some people, but it mostly is a kind of middle-ish sort of organ, so you'll know kind of where the pain usually is associated. So tell me what you know about the pancreas, so then we can run our pancreas labs. All right, produces insulin, regulates blood sugar, branch out a little further, regulating that glucose. There's a lot more to the pancreas. What else do you guys know? That is one of the things that it does. The pancreas is responsible for producing lots of different hormones, lots of different enzymes, and people think, there we are, Ashley said enzymes. All right, so let's start going over some of these, okay? And y'all get ready, because this is surprising with the pancreas. All right, so the big one that everybody knows, of course, is, let me get a better marker, is insulin, right? So we know that insulin is going to decrease blood sugar by opening up the cell and allowing the blood sugar to go in, okay? So one thing that it does for sure is insulin, and everybody kind of knows that. Now, keep in mind that insulin levels are going to be a little bit weird depending on what kind of diabetes that you have and depending on at what stage that you're in, all right? If it's a type 1 diabetic, they don't produce insulin, right? So we know that their insulin levels are going to be low to none, okay? Type 2 diabetes, it gets a little weird because if they are at the beginning of the disease process, the pancreas is going to overcompensate and make tons of insulin because it's right at the beginning when they're getting hyperglycemic. So their blood sugar goes up and the pancreas is like, ah, and so it starts to produce more insulin. Well, that can go on for a long period of time, and type 2 diabetes can go undiagnosed for a long period of time. So as your body keeps adjusting to all this blood sugar, all this blood sugar, all this blood sugar, it eventually gets really, really tired, and it doesn't produce insulin as well, and the insulin it does produce doesn't produce really that good. So when patients have type 2 diabetes, the insulin level will either be increased if we are at the beginning of the disease, or if we've had diabetes for a long period of time, the insulin levels can actually be low, okay? So you do kind of have to watch that and monitor and kind of see how long your patient has had symptoms and things like that. But we definitely are going to draw an insulin level, okay? Remember, your pancreas is not, it is responsible for blood glucose and for glucose regulation, but it's only one of the organs. Your liver does it, your gut does it, your stomach does it. There's lots of different ways that you can manage your glucose levels. Insulin is one of the ways, all right? But remember, your pancreas is also producing things in order to help your food be broken down and absorbed in the intestine, okay? So we have pancreatic enzymes called amylase and lipase, okay? So those are enzymes. Anytime something ends with an ACE, you know it's an enzyme, right? So those are enzymes that are responsible for helping us break down help me, Lord. Carbs. They help us break down carbs and fats. And so they are necessary for your body in order to break down and absorb our food. That amylase, lipase, and all of our enzymes that are responsible for helping break things down start in our mouth, right? Which is actually the beginning of our GI system. So if you guys smell cookies, that would make me so happy right now if we had some, but we don't. But if I smelled cookies right now, my mouth is automatically going to start watering because my brain has already told it to, because it says you're about to eat some delicious delights and you need to already start producing enzymes to break down those delicious delights once they hit your tongue, okay? So enzymes are produced to break things down, and in this case, it is breaking down our food so that we can absorb it and utilize it, okay? Now, what happens in something like pancreatitis, where your pancreas gets super mad and super irritated? What's gonna happen to your amylase and lipase? What's going to happen to them? Enzymes. Ashley said they eat each other. Kind of. They start to eat their own pancreas. So what happens is when this organ gets super irritated and swollen, right, because you overdid it over the weekend at Josie's bar, okay, and you drink too much and your pancreas gets all kinds of ticked off. It gets really inflamed, and it gets to the point where it's overproducing amylase and lipase because it can't release it in the normal ducts that it can normally release to because it's super inflamed and swollen. So, but the rest of your body isn't getting any amylase and lipase. So your pancreas says, oh my God, we're not getting any, we need to overproduce some, but it has nowhere to go. It's trapped in its own self. And since amylase and lipase are meant to eat things, then the amylase and lipase actually start to eat your own pancreas. Gross, right? But that's what gives them such severe pain when they have acute pancreatitis, is because their organ is digesting itself, which is sort of serious, okay? Insulin, amylase, lipase, and we also know we have to watch our glucose levels, and not just because of the insulin. What is the hormone that is produced by the pancreas that works very closely with the liver to give us blood sugar stores? Taisha, girl, you need some cookies. I know. I'm hungry too, and that's all I can think about right now. I'm gonna have to get my mind off of it, but I can't. I'm just over here sipping my unsweet tea. It's not doing the trick. What hormone does the pancreas produce that works with the liver? Remember, we said they're all interconnected. They're all having their own soap opera at their apartment, okay? What y'all think? My friend Sunny came through. It is glucagon. Okay. All right, so let's walk through what that process looks like. So the pancreas is going to secrete something called glucagon. That is a hormone that is secreted whenever your blood sugar levels get low. That glucagon hormone goes over to the liver and asks the liver to please release its glycogen stores. Now, glycogen is their sugar store. So in the liver, I want you to picture this big giant tower that's just full of sugar. That sounds like a literal dream picture, like cotton candy or something. And you know those like little towers you can just open up the door to and it all just like falls out in its glory? Think Willy Wonka here, so happy. So the glucagon is the hormone that's released by the pancreas. It goes over to the liver, goes to that big tower of cotton candy or sugar, whatever you want to picture in your mind. That's its glycogen stores. It opens up that door. Out comes sugar, it goes into your bloodstream, and you're able to absorb it as glucose. So that's how the pancreas and the liver work together to maintain glucose levels, okay? So you can see they be doing stuff on the side that they're not really supposed to be doing, okay? But it actually works, and it helps whenever you go hypoglycemic. That's kind of how they work together to help your blood sugar get normalized, okay? Now, not to to make things even more like soap opera-y, your pancreas also has some things going on with the stomach, okay? The pancreas is going to secrete some things. One of them is called amylin, okay? Does anybody know what amylin does and how it works with the stomach? All right, so let's show over here too, while you guys are answering that. All right, insulin is going to work on blood sugar. Amylase and lipase are enzymes that work on the gut. Glucose, blood sugar. Glucagon, blood sugar. Okay. Amylin, I'm doing some keywords over here so you guys can remember what laps we're going to draw, okay? Tell me how amylin works with the stomach. It is something to do with blood sugar. All right, so hi Maria. It is something with blood sugar, okay? Which is weird because we don't typically think of our actual stomach as something that regulates blood sugar, but it does. Almost every single organ you got in your body is responsible for blood sugar maintenance and homeostasis, okay? Oh, this one's a tough one. I'm not sure if anybody knows the amylin. Amylin, how this works. It is something that is secreted by the pancreas, and it senses what's going on in our stomach, and it's going to slow down our stomach. Now, why would I want to slow down my stomach doing its thing? If you're a patient, okay, and I don't care who they are, diabetic or non-diabetic, we eat a bunch of sugar if it goes into our stomach and it's working its way through and it just dumps into your small intestine, which is the biggest site of absorption. Let's say I ate 12 Krispy Kreme donuts this morning, okay, guilty, and I did that and it just dumps into my small intestine. My blood sugar is going to go and then it's going to crash on me not very long afterwards. So the pancreas got smart and was like, I got you, girl. And so it said, we're going to secrete some amylin whenever I sense that you've eaten a bit more than the Lord had intended. And so what amylin does is it goes to the stomach and it slows it down so that it secretes that food that you ate kind of in pulses, slows down that dumping. So I only get a little bit of sugar, and then I get 2 donuts, and then I get 3 donuts that come out, and then I get 1 donut. So it's slowing it down so you don't have this huge spike in blood sugar and then this huge decline, okay? So that's amylin's job, and that's how we sometimes will get something called diabetic gastroparesis. So gastro means stomach, paresis, paralyzed. So whenever their blood sugar is super high, their pancreas is like, ah! And so it starts overproducing all this amylin to slow down all the sugar coming in, to the point where it will completely paralyze their stomach and it will not move. And every time they eat, they get severe nausea and vomiting, okay? So, some of you are asking, is that somatostatin? No, they are different, but amylin and somatostatin work very similarly. They're going to do kind of the same thing, somatostatin. And the other thing about somatostatin, it also works with your brain as far as growth hormone secretion. So as your body is trying to grow and we secrete growth hormone at night, okay, you need sugar in order to grow, so it works very closely with insulin in order to make sure that your sugar stays normal even when you're growing, okay? So that's a kind of kid thing. But amylin and somatostatin do similar things, okay? So you can see the pancreas does a lot more things than we think it does, all right? So we've got insulin, amylase, lipase, glucose, glucagon, amylin, somatostatin. There's not a direct way to measure some of these things, but if we think that there is a pancreas problem, we will run an insulin level, amylase, lipase, glucose, blood sugar, right? And then we will kind of watch and see what other signs and symptoms we're expecting to see. But keep in mind, remember, I told you, if the pancreas is ticked off, you're about to take off the liver and the gallbladder, because remember, there are connections between them. So if we have pancreatitis or pancreatic cancer or something like that, and we're blocking some of these ducts, you're going to make the liver very upset, as well as the gallbladder. So that's why patients with pancreas issues, oftentimes, I'm going to put in a different color over here so that you know why, will have jaundice, especially pancreatitis. They will have increased LFTs, which we're going to talk about liver function tests in a few minutes. They're going to have increased bilirubin levels. Okay, so remember, the pancreas does all of these things, and we can test some of these. We can test insulin, amylase, lipase, glucose. If the pancreas is irritated, we also have to run some of our liver labs because we know that the liver likely will be very irritated as well. That's why you'll see, if you look on PowerPoints or in your book, when patients have acute pancreatitis, they usually turn yellow or get a mild jaundice because all of your GI organs are getting kind of mad at each other, okay? So that is pancreas and what we would expect to see. So if they have acute pancreatitis, amylase and lipase are going to be really high, right? Because your pancreas is irritated, it's overproducing all these enzymes, but they're not going anywhere, so they're eating their own pancreas. Glucose levels, they're gonna be weird and not okay, right? So anytime there's a pancreas problem, your body can either over-secrete the insulin, which causes my blood sugar to go low, or it cannot secrete insulin very well because it's not doing really good, and then my glucose will go up. A very good example of when that happens is cystic fibrosis, okay? So in cystic fibrosis, we're overproducing mucus all the time, and it goes in every single one of our organs. So as they produce mucus, it blocks up the pancreas, so it doesn't allow me to produce insulin very well, therefore my blood sugar will go really high. So patients with cystic fibrosis can get what's called cystic fibrosis-induced diabetes or cystic fibrosis-induced hyperglycemia because it's blocking the flow of insulin because there's so much mucus inside of that organ. Does that make sense? Are you with me? All right, so we kind of understand what the pancreas is doing. All right, we understand what the stomach is doing and kind of how we have to monitor that, okay? Let's talk a little bit about the gallbladder because the liver is really daunting. It does so many different things, so I'm kind of gearing myself up for that. What is the gallbladder's job? What does it do? What is the purpose of the gallbladder? You know, a lot of people get the gallbladder taken out and they will survive because we know the liver will take over. Liver's the big bad boss of all these things that are going on, right? So tell me, what does the gallbladder do? Ooh. Okay, bile. All right, let's go with that. All right, so the gallbladder is just kind of a storage place for bile. Bile's job is to emulsify or to kind of make fats to where you can absorb them. So if there's a problem with my gallbladder, it's highly associated with fat intake since bile is what's typically responsible for breaking all of that down in the gut. Now the liver actually produces the bile, sends it to the gallbladder for it to store, and then when you have a high-fat meal, the gallbladder is going to dump either through the pancreas and down, or we can kind of dump into the intestines, so that way whatever fat that you eat, okay, that bile can kind of emulsify it and prepare it for you to be able to absorb, okay? That's why whenever you have a gallbladder issue, it typically causes severe pain, but usually after a high-fat meal, because your body senses you've had a high-fat meal, you need some bile, but the gallbladder is so irritated and so fussy, or one of the ducts is blocked, that it can't get rid of it, so it just gets irritated and angry and just really swollen. And remember, since the gallbladder is all up underneath the liver, if you take off the gallbladder, a lot of times your liver functions are going to be off too, and your pancreas may start to get a little upset with us as well, okay? There are no specific labs for gallbladder, but you have to know, okay, that the gallbladder, pancreas, and liver are all connected, so we always will draw those different kinds of labs to see exactly the extent of what is going on, okay? Now, if they have gallbladder disease like gallstones, cholelithiasis, cholecystitis, there's an inflammation, it's all kinds of ticked off, okay? And does anybody remember the 4 F's of gallstones, also called cholelithiasis? And remember the 4 F's to remember who is most at risk. It's not the kindest 4 F's, and it's not the big bad F, you know, but it is not the kindest, so it's kind of ugly, but it'll help you to remember exactly who is at risk, and if they start exhibiting this kind of pain, you would suspect gallbladder disease. Anybody know the 4 F's? Okay, Maria said that obesity is a risk factor. Yes, that is one of the F's. Danae said female, fat, 40. And yeah, you got 3 out of the 4. Fertile is the last one. So, and fat is kind of ugly. We shouldn't say that anymore. But obesity or overweight, 40 or above, female, and fertile, meaning they've had multiple pregnancies. That's typically the biggest risk factors for gallbladder disease, okay? Does anybody know, and this is always on exams and it's always on the NCLEX, if you have gallstones or cholecystitis, which cholecyst always means gallbladder, okay? Chole usually means colon, and cyst usually means bladder. So you got to get your words right so you can make sure you know what they're talking about on the exam. So cholecyst, which means gallbladder, itis, your gallbladder is ticked off. Where do they usually have pain, and what is very, very like, oh, as soon as they complain of this, I know it's a gallbladder issue. What is it? Anybody know? And you have to know it because it's on NCLEX and it's on your exams and you're going to get hit with it. So what is it? Okay, it is usually shoulder pain, but it's usually referred to right shoulder pain, okay? So if the patient has a gallbladder issue, it's going to cause obviously severe pain. Typically in the right upper quadrant, they will almost always have referred shoulder pain, okay? So if they say they have nausea, vomiting, and really bad upper quadrant pain, and they have shoulder pain for some reason, that almost always means we have a gallbladder problem, okay? Especially if they fit the typical 4 Fs, okay? So gallbladder is responsible for emulsifying fats by storing the bile and releasing it into the intestines. It is closely associated with the liver, so watch your liver labs, which we'll talk about in just a minute. It is also connected to the pancreas. So there's a duct that connects the gallbladder to the pancreas. So if I have a gallstone, let's say there's a gallstone right here, okay, then nothing is able to go out of the gallbladder. There's no bile that's able to come here, and the pancreas is producing all these enzymes that it can't get anywhere. So that's how they each get kind of mad and a little angry, all right? So these are all interconnected. So you're gonna watch those labs. If one of them's mad, they all mad, okay? So that's what the gallbladder does. If we do have the gallbladder removed, then the liver will take over its function, okay? Now, okay, we're about to hit the liver. The liver is a big deal, y'all. If you do not understand the liver functions, we are going to struggle through this lab values for the liver. I would highly recommend you go check out the hepatic or liver video that we have on demand so you are sure to understand the liver. If you can understand the liver, you can decode almost everything in the body because the liver does almost everything. Okay? All right. So we are going to write a list of all of the liver lab values, which is quite extensive. I want you guys to tell me first, what are the biggest ones you typically think of when you think, oh, I got to run liver labs, like patient has cirrhosis or something? What are the biggest labs that you think of that you would want to draw? All right. I see AST, ALT, those are liver enzymes. What else you guys got? What do you typically think to run? Albumin, nice one. People forget about albumin. That one's a huge one and really big in fluid balance in the body. All right, so let's start decoding some of these and working our way through them. All right, the liver, what people typically think about the liver is it's responsible for metabolizing drugs and breaking stuff down. And yes, it does do that. And so that's why we were talking about earlier, if the liver goes down, liver isn't working, they've got cirrhosis, hepatitis, kidneys are going to go down too, because the liver does break down some things like uric acid into a more gentle formula for the kidneys to excrete. I mean, I don't know about you, but if I had to pour like straight acid out of my kidneys, it probably would be painful. I would please ask for a gentler formula like urea, which is what the liver does. So know that if liver goes down, you better be watching gallbladder, pancreas, and kidneys, because the liver has a little bit to do with a little bit of everybody. You also have to watch the brain, which we're going to talk about, okay? So this is also brain. Oh, these are terrible. Does anybody know why the liver and the brain are associated together? And why, if the liver went down, the brain going down with it? These are your kidneys, by the way. I know they look like just decrepit soybeans, but anybody know why? If your patient ever has liver issues, we always do neuro checks. We always do pupillary checks. We're doing Glasgow Coma scales. We're watching for confusion, change in level of consciousness. Yes, you guys are answering correctly. So Ashley and Danae, ammonia level. So your liver is responsible for breaking down ammonia. If your liver is broken, if you have any kind of liver disease and you cannot, it goes straight into the brain. Your brain sits in ammonia, probably not a hospitable environment, and so you will get what we call hepatic encephalopathy. Liver breaks, brain breaks. Liver breaks, kidneys break. That's called hepatorenal syndrome, because now I'm no longer breaking down my uric acid, right? So now I'm just sending straight acid to the kidneys. They're going to break as well. Liver breaks, pancreas is going to break. You can get acute pancreatitis. Liver breaks, gallbladder is going to break. Y'all do not take off this liver, okay? And I know in nursing school, it's hard not to take off your liver. You're tired. You are hurting. You just want to have a little sip of something delicious, and I get that, but please protect your liver, because your liver is really, really important to all of your other organs, all right? So the typical liver labs you guys will think of is what we call our LFTs, or liver enzymes. So our actual liver enzymes are AST and ALT. And when our liver is ticked off, it's going to start overproducing these what we call liver enzymes. So those are going to elevate. That will tell us that we have hepatitis. That will tell us that we have cirrhosis. That will say your liver is very mad at you, okay? It will also tell you if you drink too much. So if you are, you hitting the bottle every couple of nights in nursing school, your liver is going to be irritated because you're making it break down a bunch of alcohol it never wanted to break down, and those liver enzymes will elevate. Can anybody think of another instance where your liver enzymes may elevate if there's not actual liver disease, like you don't have cirrhosis or hepatitis, but those liver enzymes can shoot up? Can anybody think of another instance where that would happen? I still keep thinking about those cookies. I know y'all, I can't help it. I'm so hungry. Hold me. What would make my LFTs elevate? Sunny with the drugs, just drugs. Y'all just don't do drugs. Yes, you're right. So there are specific drug classes that are notorious for being hepatotoxic. I see somebody mention TB drugs. What other drug classes are just known across the board are going to be hepatotoxic? You have to watch liver functions every time you put a patient on these drugs, other than TB, which somebody already mentioned, which was awesome. What other drug classes are typically just hepatotoxic? Yep, rifampin is one of them. That's included in the RIPE therapy for TB. Rifampin, isoniazid, pyrazinamide, and ethambutol. That's all our TB drugs. Those are all hepatotoxic. Anytime they see TB drugs, you better just say, watch the liver, okay? What other drug classes are notorious for being hepatotoxic? Okay, Coumadin is not hepatotoxic, but it is heavily metabolized by the liver on the P450 system. Antidepressants, a couple of them can be a little harder on the liver, but not across the board, all of them. Most of our antibiotics, including macrolides, are typically more kidney. A couple of them can be, you got to watch liver a little. Some of them are liver, so you do have to watch some antibiotics. We would just watch those LFTs. The biggest ones I'm looking for that are hepatotoxic across the board, we said TB, HIV drugs, all hepatotoxic, and your antifungals, all hepatotoxic, okay? Across the board, always watch their liver, because yikes, okay? Tylenol is another one that is always hepatotoxic, especially in larger doses. So if you are going to choose to indulge in spirits in nursing school, I recommend you to not take Tylenol before bed. You would take something else, like ibuprofen, or drink some Pedialyte, or help yourself out in some other kind of way, all right? Because you're hitting your liver like pretty hard, okay? All right, so AST and ALT are our liver functions. They're included in our LFTs, okay? So that's a panel that we will run, right? Also included in the liver function tests, okay, are going to be, and I want you guys to explain most of these to me, are bilirubin, which everybody's heard of bilirubin before. A PT, and I want you to explain to me what that is and why that would be included in liver functions, okay? our albumin levels and our total protein. So if you know any of these, tell me what they are, why we would draw those. And this is a true like an LFT panel, okay? Liver function test, it's an LFT panel, and these are all included, but we're going to talk about a whole bunch more liver labs too. I just want you to understand what's included in LFT so you know what else to include, okay? What do y'all know about these liver functions and how do they work? Also, we're about to talk a lot about poop, so just want y'all to know that that's coming. Because the liver and the gallbladder both have a lot to do with your poop. All right, Sunny said that albumin is a volume expander. Absolutely. So it is a protein that can expand our volume. Let's talk about that first since you mentioned it. Okay. All right. Everybody gets kind of confused with albumin and nobody really knows who he is or what he does, but albumin is probably one of the most important things in our entire body. Albumin is a protein. So in your LFTs, you are going to draw a total protein, which gives us all proteins, but albumin is a type of protein. The liver is responsible for producing albumin, okay? Albumin is so incredibly important. And I'm going to draw this down here, but I'm going to have to erase it because I need my gut, okay? So if this is a vessel, okay, and I have albumin in my blood vessels, okay? So you've got all these albumin, which is another word for protein, right? All this albumin is in here. I want you to think of albumin like either like a straw or a sponge. It takes all this third space fluid and sucks it up and keeps it inside the vessels. So albumin's job is to keep fluid in the vessels, okay? So if we have a condition where we have low albumin, there's nothing to keep fluid in the vessels. So where's my fluid going to go? It's going to go out of the vessel, get stuck in the third space, and that's what causes edema, okay? Now, this is also one of the reasons why we get ascites with cirrhosis when the liver's broken, okay? So the liver, responsible for producing albumin. That's one of its jobs, one of its 13 jobs, okay? So if the liver is broken from hepatitis, cirrhosis, what have you, and I'm not producing very much albumin, I don't have very much of my straw or my sponge to keep all that fluid sucked up in the vessel, so it just kind of relaxes and all of the volume or the fluid is going to third space, giving us ascites. Do we understand? There are some other conditions that can cause low albumin. That's not just like hepatitis or cirrhosis. Like if the patient's severely malnourished, so if they haven't been eating very much protein, and albumin is part of that protein, they're going to have low albumin levels. They're going to be edematous. That's why whenever you see those really sad commercials where the kids are really, really like malnourished, but they have these big giant bellies, that's why, because they have a deficiency not only of calories, but also of protein. If they're deficient in protein, part of that is albumin. I don't have a lot of albumin. I can't keep my fluid in the vessel, so their stomachs appear large, even though that's just fluid from lack of albumin, all right? So albumin, totally important. And we use it for other things other than just the liver. Now, if the patient has severe cirrhosis, we are going to draw their albumin levels, which are part of their LFTs. And if the albumin is really low, we need to give them an albumin infusion. You can actually just infuse it IV, give them albumin in order to make sure that their fluid space or their fluid stays intravascularly instead of third spacing and giving them giant ascites, okay? That's one of the reasons why they get ascites. You also see in our elderly patients, they can be low on albumin as well because they don't take in as much protein and their body doesn't hold on to protein like it does when they're younger. And so we use albumin as a marker of nutrition. We also use it to see where's my fluid balance going to go. That's why you'll see in elderly clients, we recommend that they increase their protein so that way they get more albumin and they can keep fluid inside the vessel, okay? Third reason we would use albumin, okay, is for a volume expander, like somebody mentioned earlier. So if I have a patient, let's say they had they had a gunshot wound, okay, or they're in sepsis, doesn't matter, something bad happened to the body, all right, and I'm dumping all this fluid in and their blood pressure isn't changing, all right, usually that's because whenever you have a huge inflammatory response, your body recognizes something bad is happening. All your vessels are going to vasodilate. It's going to bottom out your blood pressure. And then whenever something bad happens in that vessel, it increases our capillary permeability. So any little bit of fluid, I'm going to draw it so you guys know what I'm talking about. A lot of you who go to Ivy League all the time, y'all know what I'm talking about. But there's some people who this is their first time with us, or they've only been with us a couple times. So I'm going to run through this real quick. It may be a review for some of you. So if this is my vessel, okay, anytime I change the pressure inside a vessel, whether it be high or whether it be low, it's going to increase my capillary permeability. So the capillaries are the little things that come off your big blood vessels, and they dump fluid into the cells, okay? But what happens when something bad happens, and it changes my pressure? So let's take the gunshot wound, for instance. Your patient had a gunshot wound, and your body recognizes, oh my gosh, something horrible has happened to my body. I don't know what it is, but it's bad. Forms this huge inflammatory response. The first step of the inflammatory response is to vasodilate. Well, anytime I open up my vessels, it's going to drop my blood pressure, right? So my BP is going to drop. My vessels are going to sense, oh no, something's even worse. We have a drop in blood pressure. Something has changed. It's going to increase my capillary permeability. So what little fluid I did have in here now dumps and gets trapped out into the third space, okay? Because it dumps out a bunch of fluid. It doesn't have enough power to get it back in. Now we're in trouble. So you see how these are leaky. So if I keep dumping blood and fluids into this patient's vessels, it's just going to keep going in third space. And you'll see when they're coding the patient or working on the patient, they're dumping all this fluid and blood, but the patient's getting more puffy and more puffy and more puffy. And that is because it is third spacing the fluid. So what they may do sometimes is to infuse albumin into the patient, and that way all this fluid that would normally get trapped in the third space, I add albumin and it's going to go back up into the vessel. That will get my blood pressure normalized and the patient will die of MODS, okay, or multi-organ dysfunction syndrome, organ death, okay? So that's how important albumin is and how it works. So we need albumin for protein. We need albumin for fluid volume. We need albumin to keep fluid where it's supposed to be in the vessel instead of in the third space, okay? So albumin is very important. It can give us a marker of nutrition. It can tell us how well our liver's doing or how not well our liver is doing. And it tells us, exactly what we need for our patient. We may need an albumin infusion. We may be able to tell them to just eat more protein. But albumin, very, very, very important, okay? We don't talk about it a lot in nursing school, but we talk about it here. Albumin's important. All right, so we talked about AST and ALT. Those are our liver enzymes. They're going to elevate whenever the liver's super ticked, okay? We talked about our albumin. You're also going to have total protein. So surprise, surprise, your liver is responsible for producing protein. So if you're not taking in enough protein, your liver will accommodate and make some. But if my liver is broken, it's not going to make my protein. So your total protein levels will typically be low. So will my albumin levels, right? If the liver's broken or there's a problem, okay? I'm going to write these levels up here so you know what I'm talking about. Protein level goes down, albumin level is going to go down if the liver's broken, okay? Does anybody know about bilirubin? We talk about it a lot, but do you know the patho? Do you understand how it works and what it does exactly? Who knows about bilirubin? Anybody know how bilirubin works? Everybody knows like bilirubin kind of is it's a jaundice thing, but I want to talk about why it's important and then what happens and what kind of signs and symptoms you will see in your patient when these lab levels get a little off kilter, okay? So, bilirubin is a byproduct of red blood cell breakdown. So our red blood cells have a life of about 120 days, okay? So there are lots of different conditions that can cause I'm gonna draw them over here, our red blood cells to kind of break down a little bit. Hemolytic anemia is one example. So hemo means blood, lytic means to lyse or to kill. So it's a kind of anemia that will kill your red blood cells. Sickle cell anemia can kill red blood cells. So whatever it is that's killing the red blood cells, either they're naturally dying off or you have a disease process where your body is destroying these red blood cells. As the red blood cells break open when they're destroyed, or we call it lysed. I gotta get another color, hold on 1 second. The stuff that's inside of the red blood cell goes out into the bloodstream, okay? So all this is dumped out as the red blood cell is lysed, okay? That byproduct of the red blood cell breakdown is called bilirubin, okay? So it's basically like the poop of the red blood cell, okay? So the red blood cell is lysed, bilirubin is spilled into the blood. It then goes into the liver. The liver is supposed to excrete it, okay, or metabolize it, and then it makes you poop it out, okay? You can sometimes pee it out, but mostly it's going to come out through the stool. So this bilirubin right here and this bile that's in here both give your stool a brown color. That's why your poop is brown. Hate to break it to you, okay? That's why people freak out about poop color, especially, oh my God, y'all, in pediatrics. That was a huge percentage of my patients that came in. Their parents were worried because, you know, their poop was rainbow. And I'm like, well, what'd they eat last night right before they went to bed? And they're like, a rainbow snow cone, or they ate, you know, 62 crayons or whatever. It wasn't that fun. But poop color can tell us some things. So bilirubin is the breakdown of the red blood cell. It goes to the liver to be excreted. But if the liver is broken, the liver can't metabolize all that bilirubin, and it builds up in the blood. So it's like a yellowish brown pigment, okay? So walk me through this. This is so weird, so get ready. All right. If your liver cannot accommodate all the bilirubin, or this byproduct of the red blood cells, can't accommodate it, it stays in the bloodstream, okay? That's what gives you like the yellowish color, or jaundice. Jaundice starts from the head and works its way down, and then it goes back the way it came. So we could look at babies, like before we had, you know, specific labs for each of these things, we could look at babies and say like, okay, they're yellow from here to like right here. Oh, that's probably about, their belly's probably about 11. Oh, they're all the way down to here. That's probably about an 18. And then when the jaundice starts going away, when their liver kicks in and starts working, it will go back up the way it came. It's really cool. But that wasn't even the coolest part, so hold on. So this bilirubin is like a brown yellowish pigment, right? Bile, kind of the same thing. So the bile and the bilirubin, after they go through the liver and into the intestines and are excreted, like I said, that gives our poop a brown color, right? Well, if I have all this bilirubin built up in my blood, but I'm not excreting it, then my poop will turn like a white or a clay color, which is its natural color. Isn't that creepy? And then your body will freak out and be like, oh my God, I have all this bilirubin and I can't get rid of it, and I tried to poop it out and it's not working, so I'm gonna try to pee it out instead. So when patients have major liver problems with high bilirubin levels, their poop turns white or clay colored, and their urine turns a super dark brown pigment color because your body is trying to get rid of the bilirubin through the pee. Super creepy. People get weirded out by it. They're like, why is my poop albino? You have to explain to them the process. And then we want to make sure that we increase fluids for these patients, as long as they don't have a fluid balance problem, to make sure that we can flush out all of that bilirubin, because it comes out mainly in stool, but also it does come out in urine, okay? So, do you understand bilirubin levels? If our liver is broken, these are going to be elevated, okay? Where does my PT come in? My prothrombin time, where does that come in? Sunny said, especially after Fruit Loops. Girl, you quit. Where does our PT come in? What does PT stand for? What are some normal levels, and what does it do? Oh, we also talked about, I'm going to write some of the other labs I kind of have already mentioned, but are not included in LFTs down here. We talked about uric acid. We talked about ammonia. Come on, y'all, tell me what you know about the PT. All right, coagulation, yes ma'am. Clotting, normal is 12-ish, yes. So the PT stands for prothrombin time. It tells us how long it takes us to clot, okay? Easiest way to remember it, how old is a preteen? 11 to 13, so that's about the normal range. Now, why is my clotting time included in the liver? Well, I will tell you. The liver is responsible for so many things to stop your body from bleeding, okay? So I want you to keep this in mind. Anytime you have a liver patient, they're gonna be bleeding. I don't know where it is, you gotta go find it, but they will be bleeding somewhere, okay? And here's why. Your liver is responsible for producing all of your clotting factors, all of them, and there's a bunch of them. Your liver is also responsible for producing some platelets, okay? Now, yes, your bone marrow produces some, but your liver produces some as well. Platelets, we know, clot. Your liver is responsible for producing vitamin K and also clotting, okay? Your liver is responsible for most of your bleeding times. So it also helps to produce red blood cells, right? So that gives us oxygen. So platelets, clotting factors, vitamin K, all of these things are being produced by the liver. So if you have a patient that has a major liver problem, they will be bleeding. Sometimes they have blood just oozing out their nose. Sometimes they have blood just oozing out their IV sites. Patients with end-stage liver disease, like they're about to die, they're not making it, they usually will just have like blood coming out the rectum. They'll just be bleeding everywhere, because if I don't have platelets, clotting factors, vitamin K, none of those things, okay, we're going to have a problem with bleeding, okay? So that's why we draw the PT level, so I can see, my God, how well am I even clotting, or am I clotting at all? Do we need to do some infusions of something in order to fix their problem? So the PT will typically be elevated, which means it takes me more time to clot because my liver's clotting stuff is broken, okay? So these ones up here that I have listed are all included in what we call our LFTs, liver function test. AST and ALT, which are our enzymes. Bilirubin was our breakdown of red blood cells. Liver can't accommodate, so it builds up in the body. PT is part of our bleeding time, since liver produces platelets, vitamin K, clotting factors, all of those things that typically help with our bleeding. Now, of course, it's not working well, so we're going to have increased bleeding times. Liver also produces albumin, so if the liver's broken, albumin's not going to be produced, so the albumin level is going to go down, meaning we have major third spacing issues. Lastly, on the liver function test is our total protein. Since the liver is responsible for breaking down protein, also making protein, your protein levels are going to be off as well. We also mentioned uric acid and ammonia. The liver is responsible for breaking down uric acid and breaking it down into urea so the kidneys can excrete. So if the liver is broken, it may not be able to break down my uric acid, causing a buildup of uric acid levels. So we need to draw those. Ammonia was the next one. So liver is responsible for getting rid of ammonia, which is a major toxic byproduct. Liver's broken, can't get rid of the ammonia, goes straight up to the brain, causes an encephalopathy. So in your liver patients, you have to watch for confusion and asterixis. That's where their hands will flap whenever you put them backwards. That tells me I'm getting encephalopathy. We have a major problem, okay? Your liver is also responsible for producing triglycerides and cholesterol and getting rid of cholesterol if you have too much. So we always want to draw a fasting lipid panel whenever we have a liver issue. The fasting lipid panel is going to include our total cholesterol, HDL, LDL, triglycerides, and sometimes our VLDLs as well, okay? So total cholesterol, I want less than 200, but if I have a liver problem, it can go one of two ways. Either your liver is not producing very much cholesterol because your liver is responsible for producing it in the first place. So some patients will actually have low triglycerides, or if your liver was irritated for a long period of time and it was trying to make more albumin and doing that, those cholesterol levels, total cholesterol, may be elevated. The other issue with the fasting lipid panel, your liver is responsible, right, for producing HDLs, which go out into your bloodstream, grab the LDLs, which are the bad ones, take it back to the liver and get rid of it. Well, if my liver isn't doing that, you may see an imbalance of HDL to LDL. So your HDL, I always remember H, you want it to be high because it's a good cholesterol. LDL, you want it to be low because it's a bad cholesterol. But if the liver can't make the good cholesterol or the HDL, it can't go out and grab the LDL and get rid of it. So your LDL levels are going to increase, which is super bad for you, and your HDL levels are going to decrease. So it could look very, very ugly. So that's why we draw a FLP, or a fasting lipid panel, so I can look at cholesterol, HDL, LDL, and your triglycerides, because triglycerides can elevate. So patients that have major liver problems can be at risk of thrombotic events or heart events, okay? So we definitely want to watch that as well, okay? Couple other things I really want to mention is if we have a major liver problem, we need to be drawing some vitamin levels. Does anybody know what specific levels, or not the specific numbers, but which vitamins the liver is responsible for producing, storing, synthesizing? And those are the biggest ones that we have to watch for. All right, so I'm seeing some answers come in. Very good. So all of our ADEC, okay? So we will draw our B's, okay, all of the B's, and A, D, E, and K, okay? So we typically will be deficient in a lot of these, especially my B vitamins. Nobody hardly talks about B vitamins, but they're super important. So all of my B vitamins are nerves. So that's why nerve health is what I mean. That's why whenever you have a patient that's an alcoholic or that has cirrhosis, they typically have peripheral neuropathy. Their nerves get all irritated because the B vitamins are not being produced like they normally should. That is also the reason why cirrhosis patients feel so fatigued and so tired. They don't have those B vitamins. Another reason why they're anemic. Almost all of our liver patients are going to be anemic because they don't have the B vitamins to produce the healthy red blood cells, so they become severely anemic. It's a big, big problem. So these B vitamins are really important. So whenever you have a patient come into the ER and they're drunk They give you a banana bag. They call it a banana bag because it's yellow, because it contains a bunch of B vitamins. You ticked off your liver didn't want to produce those Bs, so it's going to have to give you the B vitamins back that you need. Okay? All right. Let me see if there's anything else I want to mention to you guys too. Oh, since we are at risk of anemia, right, because we're deficient in some of these different things, whenever we have a liver patient, we also will draw a CBC, right? So that will give us our H&H. It'll give us what our red blood cells look like. So it's important to draw that to kind of see what is going on and how anemic that I am. Do I need any treatment? Okay. Another big thing that you need to think about with liver too, our liver holds all of our iron stores, okay? So remember we talked about how there's a big sugar store in the liver, okay? So we need to watch glucose levels too, right? But there's also a big storage tower of iron, okay? And that big storage tower of iron keeps enough store, so when you go low, it gives you those stores of iron. Well, if my liver's broken, it's not going to hold those stores for very long. They're not going to work effectively, so your patient may also have iron deficiency anemia. So that's another reason why watching the CBC will be so important in your liver patients. Okay? Whew. Oh, hang on. Are y'all still with me? The Wi-Fi went kind of wonky for a second. All right. That's a lot of lab levels to draw, or labs to draw for a liver. AST, ALT, bili, PT, albumin, total protein, CBC, uric acid, ammonia, fasting lipid panel, vitamin levels of Bs and A, D, E, and K, iron, glucose. You see how much your liver does and how important it is for you to understand what it does so that way you know what lab levels you need to draw, okay? We might even draw some vitamin K levels, okay? Hopefully y'all are still with me. Let me think if there's anything else I want to tell you guys before we stop. Oh, here's the other one that nobody ever knows, okay? Does anybody know? Let me see where I write it. Right down here. Alkaline phosphatase. What is that? We know it ends in A, so it's got to be an enzyme. They love to ask about this lab. We call it an ALK-PHOS for short, okay? It is an enzyme that is produced when your liver is ticked or your bones are ticked off. So liver and bone. So let's say a patient has leukemia or they have a Ewing or osteosarcoma, cancer in the bone. Any major bone, what these lab levels are and what they mean. Now, I have hardly ever in nursing school seen them ask you levels on a lot of these things just because they're different for every lab. Now, fasting lipid panel, you do need to know. You need to know your total cholesterol should be less than 200, triglycerides less than 150. For the fasting lipid panel, I always use the rule of 50s. I'll draw it up here really quick. So you just start at 200 and go backwards by 50, okay? So cholesterol should be less than 200. Total triglycerides, oh here, I'll write it over here. Total cholesterol should be less than 200. Triglycerides should be less than 150. LDL should be less than 100. HDL should be greater than 50. Okay? Easier